I don't think a week goes by, sometimes a day goes by, that there isn't something in the news about something going on in diabetes, and that's been true today. It's just been an amazing few years. One of the things that has really caught our fancy in the Diabetes Care Center here, and I think the number one topic discussed by our patients, especially our patients with type 1 diabetes, which is half of our clinic, is the whole topic of real-time continuous glucose monitoring, or real-time CGM. And that's what we're going to talk about over the next few minutes. And I was asked to talk about the question, is this just a true revolution, or is it just another fad in diabetes as we have seen in the past? So these are the objectives I was asked to place up today, about reviewing how this whole thing works, looking at the current randomized controlled trials on the effectiveness or lack thereof, and review some of the practical issues we are dealing with in our clinic managing patients with real-time continuous glucose monitoring. Now, some of you in the room may remember some of these. I hear some snickers around the room because, and I understand that, going back to some of the very early urine testing from the 1930s and 1940s. Mike, do you remember this? Maybe not. The 1960s and 1970s, and things really changed in the early 1980s when we could start doing relatively less barbaric finger pokes with devices such as this, the Autolet, using this first glucose oxidase meter, which was called the iTone, and then coming to the dextrometer, and then some of you may remember these visual chem strips. And of course, more recently, the technology has improved quite a bit. Instead of a 2-minute test with washing, they're now just a few seconds, and they have become much more accurate. Many companies make these, and it is obviously a major economic issue for patients with diabetes, but it has also revolutionized care. And I remember as I'm sitting here thinking about this, I came to the University of Washington in 1990, and one of my first academic debates was with one of the primary care physicians who was convinced this technology, the fingerstick glucose testing, was just a fad and there was really no place for it in clinical medicine. That was 1990. But this is where we are in 2008. We have real-time continuous glucose monitors. There are 3 of them on the market. We will talk a little bit about each one. There's this one from Dexcom, there's this one from Abbott, and then there's this other one, a sensor-augmented pump from Medtronic Diabetes. Now, how does this work? How does continuous glucose monitoring work? Well, there are 3 devices on the market, and 2 of them, the Dexcom and the Medtronic, use a more traditional glucose oxidase technology. And what happens is that glucose will then combine with water and with glucose oxidase make gluconic acid and hydrogen peroxide. And this hydrogen peroxide is what is important because under the influence of a current from a transmitter that is connected to the sensor, there is a charge that is released, and this charge is proportional to the glucose. So the higher the amount of hydrogen peroxide means the higher the amount of glucose and the greater the charge that is generated. And those of you in the audience who are chemists, and many of you are, will realize that there's got to be a problem with this hydrogen peroxide because there are so many potential interfering substances with hydrogen peroxide. And that is one of the problems with the current technology as we know it today. Now, this is for 2 of the sensors. There's another one on the market from Abbott Diabetes outside of San Francisco. Their device is called the Navigator. They were actually the last ones to be approved by the FDA. And for purposes of CME, I should point out all of these devices are approved by the FDA. Now, this one is different in that it does not rely on oxygen for signal generation, and therefore this results in minimal sensitivity to the in vitro oxygen variations. Let me get this pointer. There we go. And also, the operating potential that we discussed for the other 2, it's much lower than the other 2. And because of that, this is probably the reason that there is more accuracy, at least a little bit more accuracy, when we look at the data for accuracy between the 3 different meters. This is the Medtronic meter, where the sensor is inserted at one part of the body, and here's the transmitter, and the transmitter will then in this case, go to the patient's insulin pump where there is a radio frequency to the pump where the glucose level is then read. And you can see a little bit closer what this looks like. This is an insulin pump. I should point out that this particular meter also works as a standalone device without an insulin pump. So this is called the Guardian. From the outside it looks the same, but no insulin is actually provided. But the one nice thing about this particular device is that the insulin pump and the sensor is all integrated into the same device. And this is going to become the norm over the next year or two as all of the sensors will be integrated with pumps. So the sensor is at the end of this catheter. It's very tiny. Here's the transmitter, and this is what the patient actually sees. And I want to thank David Chu for allowing us to show what it looks like on him. People have gotten extremely creative. Sorry, David. People have gotten extremely creative where they wear these, and they wear these sensors, and for that matter, pumps, every part of the body imaginable, and I'll let your imagination figure out what I'm talking about. This is the Dexcom device. It's a relatively small transmitter, and this is the actual receiver that the patient actually sees. And then this is the Navigator, where here is the sensor and the sensor mount. The transmitter goes on top of it, and then it then relays the information to the receiver. And then, and then here you can see the small catheter where the sensor and sensor mount is placed. And all of these devices are measuring the interstitial fluid glucose. Technically, the Dexcom is not looking specifically at interstitial fluid glucose, but for the purposes of our discussion, we can say that it does. So what happens is the glucose comes into the interstitial fluid, and it's this interstitial fluid that is actually picked up from the sensor, this interstitial fluid glucose. So is this technology accurate enough for clinical use? I mean, that's really the question. And if we go specifically by FDA labeling, we need to appreciate the fact that none of these devices are labeled for standalone, meaning one still has to continue to do finger sticks to make insulin adjustments, insulin dosing, number one. And number two, one still has to continue to calibrate these sensors depending on the device several times a day to keep them working accurately. This was a study which right now is the most quoted study comparing the three devices, looking at a variety of different metrics, comparing accuracy. They did glucose clamps, first one at euglycemia in these individuals, and looking at the mean absolute relative difference compared to the reference, you can see that the Guardian was a 15%, the Navigator was about a 15% MARD, whereas the Dexcom was higher. It was 21%. They also looked at the ISO International Standard Organization, looking at the percent reading within 20% of the reference when the reference is above 75 milligrams per deciliter. And you can see that the Guardian and Navigator, again, were in the same ballpark. Dexcom was significantly less. And then when hypoglycemic clamps were done on these patients, looking at the MARD, you again see that Navigator does the best, Guardian second best, Dexcom does the worst. And as far as the ISO reading, looking at the percent within 14 milligrams per deciliter when hypoglycemia occurred less than 75, again, Dexcom did the worst. And I want to show you this study because, number one, you can see none of these are really greatly accurate. They give you a ballpark. But I also want to present this study because this is somewhat of an unfair study for several reasons to Dexcom, because Dexcom is now on a different generation device. In fact, all of these devices probably have an 18-month to 24-month duration for each generation of the device. Dexcom actually is getting ready to go to a third generation. This is comparing their first generation device with the other two. Dexcom actually came to the market first, and that is the reason why it appears to most of us, Dexcom did not do as well in this particular study. And therefore, I want to show you the current device, some data. First of all, looking at the lag time, and we're going to talk about lag time in just a moment. That is the time between what the actual blood glucose level is compared to what the interstitial signal is showing on the receiver. They show a 5-minute lag time, which is actually less than the other two devices. And they also showed something very interesting because we are now thinking about glucose as rate of change. And we've been doing this for a few years in the hospital when thinking about IV insulin, but now we are thinking about rate of change on the outpatient basis. And what Dexcom reported was that the rate of change does not appear to impact accuracy. Since the MARD, the mean absolute relative difference, is not dependent on the rate of change, Dexcom claims calibration is not impacted by the rate of change. The other two companies make a very big point that when patients calibrate the sensors, the glucose level ideally is flat. And when we look at the MARDs in this far column compared to the rate of change, less than 2 milligrams per deciliter per minute, all the way to greater than 2 milligrams per deciliter per minute, you can see that the MARDs now are in the same ballpark as the Medtronic and the Abbott sensor. And this is important. I should also point out that we have become very, I think, more savvy about this whole topic of rate of change. We have learned, for example, that glucose levels are much more variable in children than in adults. And we have also learned that we have learned how to adjust insulin when that rate of change is going up more quickly compared to down more quickly. We've learned, for example, that it's relatively rare to have a rate of change go up or down more than 2 milligrams per deciliter per minute. But that can happen, and it does happen. And again, it happens more often in kids. Now, this real-time continuous glucose meter nomenclature is probably not completely accurate because nothing here is actually real time. Now, these are actual data when one looks at capillary glucose in red compared to the interstitial fluid glucose in blue. And what you see here is that if somebody eats a meal at time 0 and then one wants to calibrate over here, because of this lag time, the actual glucose is 170, whereas the interstitial glucose is 140. And because of that, one could actually have an inaccurate calibration because of this lag issue. Now, patients need to know this, but what they really need to know more is from this slide, and this is a slide that I just drew, but I think it is also very accurate, where again, we see a lag between the actual capillary glucose and the interstitial fluid glucose. So in this example, if one exercises down here at time 0, the actual glucose is 65, the interstitial glucose hasn't caught up yet, and the interstitial glucose on the sensor says 90. So if that glucose level is going down, you can rest assured that the actual glucose is actually further down than the interstitial glucose says on the sensor. Now, this is quite important. We had a patient just a few months ago in clinic who checked his blood glucose in clinic. His blood glucose was 105, 106 on his meter. He had no idea that his blood sugar was crashing very quickly, and that's exactly what he did in his car as he left with his son in the back seat. So the change of glucose is a whole metric of glucose and diabetes that we are now paying quite a bit of attention to that we were not able to pay attention to with patients doing 6, 8, or even 10 glucose levels a day. When one is getting a data point every 5 minutes, we can really see the rate of change and the actual trend of the glucose. Can this technology improve glucose control? And of course, that's what everybody wants to know. And this was the first study we did. This study was funded by Medtronic Diabetes. We looked at 138 adolescents and adults with type 1 diabetes between the ages of 12 and 80 years of age. They had to have type 1 diabetes, and all of these patients in this particular study were on an insulin pump. CSII stands for continuous subcutaneous insulin infusion. They all had to be on pumps. They had to have A1Cs greater than 7.5, and they had to be measuring their glucose levels at least 4 times a day. 29% of them were adolescents. The rest adults mean age of about 41, very typical for our clinic population. The fact that 90% was white is what one would expect in type 1 diabetes, which is mostly a Caucasian disease. Over half in our study were female, and the mean duration of diabetes were 18 years. We published this recently. We presented this last year at the American Diabetes Association meetings in Chicago, and what we showed was no difference. There was no difference between the group wearing their pumps alone and the groups wearing the sensor in yellow. There was clearly a study effect, but the overall bottom line of the difference between the two groups, there was no difference at 26 weeks. And notice here that the A1C starting the study was between 8.4 and 8.5%. A very important point, but it didn't make a difference. Some of our secondary endpoints did show significant difference. For example, the number of patients with A1C levels less than 7% at the end. The group receiving the sensor-augmented pump therapy did better than the control group. And this may be the most important slide from this particular study, looking at percent sensor usage. Now, we use the word compliance. A lot of people are upset with the fact that we use that word compliance. We define compliance, I would use the word adherence maybe, as using the sensor at least 6 days a week. That was the goal. And what you see here is that those individuals using the sensor at least 6 days a week, or 80 to 100% of the time, or even 60 to 80% of the time, had a 0.7 to 0.9% reduction of A1C. What we're saying is, when they wore it, it actually worked. For those individuals who wore it less than 60% of the time, there was no change in A1C, and notice that the baseline A1C here was 9.5%. So for those individuals who in 2007, when we did this study, actually 2006, for an A1C level starting at 9.5%, putting the sensor on is not going to make a difference. And that made total sense to us. And the reason why it made total sense to us is that in 2006 or 2008, if you have an A1C that high, that means you're not doing the basics. You're not giving the insulin when you eat. You're misdosing the insulin. Maybe you're missing it altogether. You're paying no attention to the basics. So maybe this technology shouldn't be considered for individuals with A1Cs in the 9% range and above. But if your only endpoint is looking at A1C reduction, you have to look at somewhat of a higher A1C. But above 9% with our usual care today isn't the way to do it. So where we were after this study, with the acronym was STAR 1, was that increasing use and patient enthusiasm by type 1 diabetes in sensor-friendly centers. Because quite frankly, even today, there's little interest for this technology by most, if not many physicians, because of the extra time involvement that it takes in the offices and the clinics to teach and to utilize this therapy effectively. Poor insurance reimbursement. As a matter of fact, Washington State is one of the worst, if not the worst in the country, at least until a few weeks ago, for the use of real-time continuous glucose monitoring. And in our clinic, we saw growing use by those who could afford it. Patients were paying cash for it, and they're still paying cash for it. And anecdotally, we saw tremendous improvements in quality of life for those who wore it. And we have come up with an entire infrastructure, including pre-sensor classes, so patients had realistic expectations about what to expect when they started using this technology. There have been obviously some negatives. This isn't all a wonderful story because there are the accuracy issues, which you have already seen some of them. The alarms, where we set the alarms when they go off for highs or lows, can be a nuisance depending on how we set them for individual patients. Many patients have unrealistic expectations, and some of this was exacerbated by aggressive industry representatives, not to mention the cost of this as patients were paying for this, and most of the country still paying for this out of pocket. So there are many issues here, and what's very interesting is going and lurking on some of the internet blogs for patients who are talking about this who feel like they've sort of been had by some of the unrealistic expectations that they were led down the road. And so if we go and we actually look at the costs between the three sensors, for those patients who pay cash, this is what we see. These are the startup costs for the three different sensors between Dexcom, Medtronic, and Abbott. And notice that I have ranges here for the monthly costs. And the reason is that all of these devices have approved indications for how often they need to be changed. But if you're paying cash for this, you're going to use it as long as you can. And so on the low end of the cost, this is mostly anecdotal from our patients for how long they can wear each sensor. I will tell you that the Dexcom 7 is approved for 7 days. That is why it is called the 7. The Medtronic Guardian and their sensor for pumps is approved for 3 days, and the Abbott Navigator is approved for 5 days. But patients will go ahead and wear these things for as long as they can. And in fact, if you go on the internet, you'll see that occasionally patients can get up to 3 weeks with one sensor. Most patients, depending on the sensor, can't go that much longer than what the approval is for that particular device. So that brings us to what we presented just a couple of months ago. The Juvenile Diabetes Research Foundation, the Jdrf, sponsored a study on real-time continuous glucose monitoring. We included those individuals with type 1 diabetes at least 1 year duration, individuals over 8 years of age with A1Cs between 7 and 10. And this is where I was very strict. I was, on our conference calls, very much against bringing people into the study with A1Cs above 9 from what we saw in the other study. And even though I did not win that argument, we were able to use, I think, better patients for that technology. Patients using an insulin pump or at least 3 injections per day. And what is not on this slide is that the average frequency of testing for these patients, as I show you this data, is between 6 and 7 finger sticks a day at baseline. These are patients who are really working to try to manage their diabetes better. We excluded significant psychiatric problems or patients with other medical disorders, and we certainly were not 100% on that, as I'll show you in a moment. And they could not be using real-time CGM for the past 6 months. And anybody pregnant or planning to become pregnant was also not allowed in the study. Prior to starting the study, we decided we were going to analyze the data based on age group, and that's a very important thing that we did. So we looked at the adults who were over the age of 25. Here's my pointer. Notice the numbers here. We had those between the ages of 15 and 24, the adolescents and young adults, and we had the younger children. Overall, we had over 300 individuals in this study. We presented this in Rome on September 8th, and it was really amazing. We learned the last patient came through this study May 30th. We saw the data for the first time June 8th, and we were in the New England Journal by September 8th. This is how I spent my summer. Notice the A1Cs. Now remember the STAR 1 study. In the adults, which we had the highest enrolling adult site here at the University of Washington, notice that our mean A1C was 7.6%. It needed to be above 7. We were at 7.6. Notice that the teenagers and the children were at slightly higher A1Cs. So patients would enroll. There was a run-in phase where they would wear a blinded sensor. We also wanted to make sure they could continue to wear the sensor. They were then randomized to either real-time CGM or usual care, whether it was multiple injections or pumps. And then what I'm going to show you is the 6-month outcome. So we're just going to talk about this part of the study. I will tell you that the 12-month outcome, we do not know the data yet. We will learn it in a couple of months. We will be presenting these 12-month data at the ADA meeting next summer. And here are the study results. In the adults, it worked. It worked great. We started at 7.6, and you can see at 13 weeks, A1Cs came down nicely, and they stayed down at 26 weeks. There was a little bit of a study effect in the control group. We came back up to baseline, greater than a 0.5% reduction in A1C. It worked. If we looked at the secondary outcomes for the adults, what we see is we had more people with A1Cs less than 7%, more people with a greater than 10% drop in their A1C, and more people who dropped an absolute amount of their A1C by 0.5%. It worked, it worked, it worked. In the adults, it worked very well. And if we looked at the change in A1C for those greater than 25 years of age, you can see it was a 0.52% difference between the two groups, and that's starting with an A1C of 7.6%. It's hard to get a 0.5% reduction when you're starting with relatively well-controlled diabetes to begin with. What about the children? Well, in the kids, there was no difference. There were some differences, whether it was an 8 and 9-year-old compared to a 13 to 14-year-old, as you would expect, but as a group, when you look at it like this, it didn't work. On the other hand, all of the secondary A1C outcomes in the children, you see it was effective for getting more kids less than 7%, more kids getting a greater than 10% drop in their A1C, and more children an absolute drop by 0.5%. Of course, this particular age group, much of the diabetes is managed by the parents. What about the monsters? I mean the teenagers. What happened with this group? Well, it's not pretty. When you look at the data at first blush, there was no difference in A1Cs in those individuals who were wearing the sensor compared to the control group. That's the bad news. What I'm about to show you, you will not see published in any journal, at least not yet. The New England Journal of Medicine editor, I should say one reviewer in particular, did not think that this was an appropriate analysis to publish. We did show this when we presented the data in Rome. I am not allowed to share this slide, but I am allowed to show it to you. And what I'm showing to you, I believe, is the most important slide of this entire protocol. What you see here in the gray are is the usage data for CGM. What you see in the gray specifically are those individuals using the device at least 6 days a week, so 6 or 7 days a week. And what you see in those above the age of 25, if one wore it 6 or 7 days a week, which was 83% of the population, there was this significant greater than 0.5% absolute drop in A1C. When we look at the teenagers and young adults, a third of them wore it greater than 6 days, at least 6 days a week. And for those third who wore it at least 6 days a week, they also had a 0.5% drop in their A1C. Surprise? When they wore it, it worked, even for the teenagers. And for the little kids, half of them, 50% of them wore it 6 or 7 days a week. And when they wore it 6 or 7 days a week, they actually had the greatest reduction of about 0.7% of their A1C. So when they wore it, it actually worked. You can't do this in an intention to treat analysis, but then when you go and look at how often they actually wore the device, it actually worked. And this is exactly what we saw in this first study, the STAR-1 study. So the requirements for success, at least on the adult side, good understanding of the basics of insulin therapy. Now this, I don't want to gloss over this. This is important. Many patients do not understand the basics. The average patient who comes into our clinic for the first time has never really been taught the basics. So this is important for somebody learning to use this technology. Patient attitude and perspective, very important. They have to be motivated. They have to have little fear of new technologies. And quite frankly, this is why we had to spend more time and we had more issues with some of the older patients who were not really literate with computers. Ability to react to trends and not the specific numbers. Remember the accuracy issues. The accuracy is certainly better than it was a couple of years ago, but it's not perfect. It's the trends that are important. When the glucose level is going up, you need more insulin, bottom line. The ability to accept that previous perceptions regarding one's own diabetes may incorrect, and one needs to respond to certain types of foods differently, or lag time, specifically waiting between giving that insulin dose and eating. And in fact, that last issue, from a behavioral point of view, is probably the single most issue that patients change, knowing that they need to give their insulin 10, 15, 20 minutes before they ate to have that insulin have its greatest impact, because now they can actually watch and see what it's doing to their glucose level almost real time. And then, of course, what we showed in both of our studies, the willingness to wear the device most of the time, ideally 24/7. It doesn't work if you don't wear it. Other issues with adults has to do on the side of the provider and the provider's attitude and perspective. Ideally, working with a team of clinicians expert in diabetes and insulin management. I am very fortunate in that I am able to do this here in the Diabetes Care Center at the University of Washington. But the average clinician in practice doesn't have this luxury, and this is what makes it so difficult. The ability to accept preconceived notions about insulin treatment may be incorrect. I got to tell you, I was wrong over and over and over about what I thought we should do with insulin, but when we saw what was happening in our weekly meetings, when we reviewed the downloads, we saw that we needed to make adjustments that we were not ready for. The ability to appreciate that successful insulin therapies can be extremely variable from patient to patient. What works in one individual may not work in another, and that is something else. There's no cookbook to this. Appreciation that there is a significant time commitment both for initial training and ongoing follow-up. And this is a huge issue from a provider's point of view because from a business model perspective, there is really no way most providers can do this in their office because it's one thing to have the reimbursement for the device, but the provider who's doing this in their clinic, he or she needs reimbursement too, and that's right now not part of this whole model. And that's what needs to change, and that's the biggest problem with this entire discussion is that the physicians are not really interested in this until they can get reimbursed for their time. Other implications, like all modern-day diabetes therapies, success is still patient-dependent, and continuous glucose monitoring is simply another tool to assist in improving diabetes control. Patients who do best with this technology are those who change their behaviors based on both the real-time and then the retrospective review of their data when we download it. And I got to tell you, if you go around the country and look at those clinics that download glucose data outside of pediatrics, it's minimal. Minimal endocrinologists, let alone primary care physicians, download glucose meters, let alone insulin pumps or continuous glucose monitoring devices. And that retrospective review is really what gives patients the aha moments when they see what they're doing wrong. Successful use of real-time CGM requires more, not less attention to diabetes management, and it's no different than insulin pump therapy. Patients need to realize that none of this is a panacea. It's not closed loop yet, and patients still have to make daily decisions, often hundreds of decisions a day, about what they're going to do with their insulin and their food. Other implications is that successful use of this technology in adults with moderately well-controlled type 1 diabetes can result in less hyperglycemic exposure and less hypoglycemic exposure. These data were presented in Rome by Howard Wolpert from Boston, and we clearly show less variability and less exposure to the highs and the lows. But in addition, reduced A1C levels and an overall reduction of the burden of diabetes-related complications for patients with type 1 diabetes. Let me repeat that. A reduction of the burden of diabetes-related complications for patients with type 1 diabetes. I mean, this technology has been shown to work, which is why I'm glad we have representatives from the insurance industry here today, because not covering this should not be an issue anymore. This is data from the DCCT. Now, why would I show you a slide from 1993? Well, we were involved in this study too. And this is a slide looking at progression of retinopathy, significant progression of retinopathy, as it pertains to hemoglobin A1C level. We're looking at over here on the y-axis the rate of progression of retinopathy per 100 patient years. And if we now extrapolate that to this data, on average the reduction of A1C over 6.5 years would result in a reduction of diabetes retinopathy progression of about 2.7 cases to 1.9 cases per 100 patient years. Now that may not seem like a big reduction, but if you are one of those people developing proliferative retinopathy, that is absolutely huge, a very big point. But maybe more importantly is something we haven't talked about yet. And that's the whole issue of hypoglycemia. Because let's face it, this is really the rate-limiting factor of the management of anybody on insulin, but particularly type 1 diabetes. Now, these are the data, again, from the 1993 publication of the DCCT, looking at the rate of hypoglycemia as it pertains to hemoglobin A1C, and we are talking about severe hypoglycemia, which we define as requiring the assistance of another person. So this is where we were in 1993 with our current with our tools from that era, and this is where we are right now without CGM, with insulin analogs, better use of pumps. We are right here, well below the line from where we were in 1993 for the incidence of severe hypoglycemia. Now, I got to tell you, we sort of know this. We know we don't see as much hypoglycemia now as we did in the late 80s and early 90s, but to my knowledge, this is the first time that we've been able to quantify this and compare it to the DCCT. Now, what I then did was I wanted to see where we are now compared to the DCCT, but what I had to do is I had to take one of our patients out of the analysis, and I want to be very upfront about this. Remember when I said that if you had psychiatric disease, we didn't want you in our study? Well, one got through, and we had somebody who, not in our center, but we did have a patient who had 6 suicide attempts with insulin. So in all fairness, I took him out of the analysis, and even taking him out of the analysis, based on the curve, you would expect the hypoglycemia to be down here since the average A1C was 7.1%. But this is where we actually went. It went down. Not statistically down, but it went in the right direction so that we certainly don't see more hypoglycemia even though we reduced the A1C. Again, this is not completely valid data since I took that one individual out, but I think it's very important nevertheless. Now, what about kids? We didn't talk about kids because we didn't see the kids here in our clinic, but these comments come from Lori LaFell at the Joslin Clinic in Boston, and she noted that parents seek improved approaches to care, the parents provide the consent, often the youth go along for the ride. She also noted that youth expect the devices to make management easier, and there are often unrealistic expectations for a cure with an artificial pancreas. Parents of younger children remain involved, but parents of adolescents often disengage with increased adolescent autonomy and the need for privacy. And this is a huge issue with managing teenagers with diabetes. The parents of younger children often fear hypoglycemia more than the high blood sugars. And it's the hypoglycemia that they are so fearful about. Children do not often look at the receiver, and the adolescents ignore the alarms. And so even when they are wearing the device, they may not be getting all out of it that they could. What patients are not addressed by the Jdrf artificial pancreas project? Well, type 1 patients with A1C levels less than 7%. I can tell you that we had a sub-study in those individuals, less than 7%. That study has been submitted for publication, and hopefully in the very near future I'll be able to talk to you about that. But as of now, I cannot talk about it. Poorly controlled patients. We had very few individuals in our study with A1Cs over 9%. And quite frankly, I don't think those are people who would really benefit from this because they're not doing the basics of getting their A1C levels down. And I should point out, this is assuming that they are in a multidisciplinary diabetes clinic where at least they have access to getting their A1Cs down with appropriate education. I can't say anything about type 2 diabetes from our data. We didn't study type 2 diabetes. I also can't talk about pregestational women with type 1 diabetes or women with gestational diabetes. We did not study that. Or we did not study older patients with type 1 diabetes, specifically those of Medicare age. We just only had a handful of people in that age group, so I can't really comment on that. Or other less common forms of diabetes. Cystic fibrosis-related diabetes, we see a lot of that in our clinic, and individuals with one of the different forms of monogenic diabetes. We didn't really study those individuals. Other practical considerations to be considered for clinicians: group classes or pre-CGM training so patients gain realistic expectations. And this is a huge issue. We have developed pre-sensor classes where patients can actually come in with their family members, look at all the different devices, press the buttons, and make a decision what they want to do, and we give them realistic expectations as opposed to a website or some other material which may be biased. Offices and clinics ideally are computerized for downloading the data. As I noted, the majority of endocrinologists don't download the data, and you have to be able to look at the data to get the most out of it. Clinic staff and educators readily available for downloading, training, problem solving. If I had to do this by myself, or if we as physicians had to do this by ourselves, we could not do this type of therapy. Administrative assistant for patient reimbursement issues. Again, the amount of administrative burden for this type of therapy is huge, which is why many endocrinologists, if not most endocrinologists, don't want anything to do with this. So ideally, an entire clinic infrastructure is present for the most efficient and effective use of CGM, and I'm sort of giving you a half-empty glass full view of this. It is my hope that the reimbursement for all of this changes so that there will be more enthusiasm amongst the endocrine community to do this in their offices, because realistically, we now have the data. This does work for these patients. Now, why differences in this Jdrf study compared to the STAR1 study? Well, it's actually pretty simple. In STAR1, we started with 8.4% A1C, and only 25% of individuals wore the device 6 or more days a week. And in the Jdrf trial, we started with an A1C of 7.6%. It was a different population. 83% wore it 6 or more days a week. So in this latter study, it's a different study population than the first study, resulting in differences in the primary outcome. We learned the hard way that we had to pick our patients differently, and the way the technology works, you have to pick the patients appropriately, and that's what we did in the second study. So as far as the study is concerned, successful management of type 1 diabetes continues to require a large amount of effort from patients and their families. No approach to the management of type 1 diabetes is ideal due to the difficulties in insulin replacement and all of the human factors involved, and it's huge. I would conclude that this study was a huge success, even though if you just read the abstract of the New England Journal paper, you're sort of scratching your head saying, what's the big deal? It didn't work for the kids very well, and it certainly didn't work for the teenagers. Well, if you look more closely at the data, it actually did work if they wore it. And this kind of gives me chills every time I show this slide, and that is CGM can have a tremendous benefit for the management of type 1 diabetes and should now be considered the standard of care for appropriate adults, that is, those already practicing state-of-the-art intensive therapy with type 1 diabetes. This is now standard of care based on this study. Now, this is how we use this technology, and this is how we teach this technology. This is a part of a download of a 38-year-old man with type 1 diabetes. He's on an insulin pump. Let me get the pointer here. And what you see here is this is his finger stick glucose. This is his glucose sensor tracing. These are alarms that go off. These are his insulin boluses here from his pump, because all of this is integrated on the Medtronic device. You can see the bolus is provided here when he checks his glucose level here, right there. He then got an alarm. He got an alarm when his glucose level went above the alarm threshold, which in this case was 200. So what happened? He looked at his pump, and his pump did the calculation, and based on the glucose of 200 and based on how much insulin was still available from the last bolus, the pump gave him a calculation, and it gave him a correction dose based on his blood sugar and the insulin on board from the last bolus. And this is what was given. But there was a problem, and the problem is the trend of the glucose is going up. And the correction dose that the pump suggests does not take into account this glycemic trend that the patient can actually see. And so what we do is we teach our patients that when they see that trend going up, they need to give more insulin than the pump actually suggests. And what we teach the patients is trend trumps insulin on board. And this is what this is all about. So if the glucose level is going up, more insulin is required. The alarm went on again. The alarm went on again, and so what the patient did was that the patient went ahead and gave himself another bolus. And this is how this technology works. Now, there are other downloads depending on the device. This is the Dexcom download, and you take one look at this and you know exactly what the problem is. In this situation, the patient needs to work on dinner time insulin dosing, but it also has to be watched. Watch this patient. The sensor ended its life right here. The patient then put the sensor back on after the warm-up period. 4 units of insulin was given. The patient did not watch it. And then right down here at about 4 o'clock in the afternoon, he woke up with paramedics giving him IV glucose in his car because he wasn't watching it. It doesn't help you if you don't watch it. Here's a 17-year-old girl with depression. Welcome to my world. I mean, this is what we see. These are tough, tough, tough patients. What's the diagnosis here for this lab medicine group? Well, she's wearing the CGM. Let me tell you, you can see there's a lot of hypoglycemia here. This is a range over the course of a few weeks. Whoops. But what you also see, these blood sugars up to 400. This is 1 dose of acetaminophen, Tylenol. Remember the hydrogen peroxide business? You can't take acetaminophen with this device because the hydrogen peroxide, mistaken from the metabolism of the acetaminophen, sees that it's metabolized to hydrogen peroxide and it interprets that as glucose, and it goes off the chart. Here's the final case. This is a 28-year-old woman. She's had diabetes for 15 years. She used to have anorexia. She now tells us she's recovered. Her BMI is 22. She's on an insulin pump. She's never been pregnant. Her A1C is not ideal. She goes on the device, and this is what we see. This is what we see when we download these devices. She gets an alarm, and I will tell you she's home alone. Her husband's out of town. It's a Friday night. She checks her blood sugar, and what does she do? She gives herself a correction dose. She does the right thing, right here. But then, after that, she gives herself insulin. This is carbohydrate she eats, and she gives herself insulin for that carbohydrate. And then what does she do? She gives herself insulin again for carbohydrate. You know, we're at 2 o'clock in the morning. So she stacks her insulin on top of each other. She goes to sleep, and her glucose level is going down. Again, she's home alone. What you then see is the alarm goes off when it gets to the threshold of 70. 20 minutes later, it goes on again. 20 minutes after that, it goes on again. She finally wakes up. If this was a guy, he would run down to the fridge, drink some orange juice, and go back to sleep. But remember, this is a woman with a previous history of an eating disorder. What does she do? She turns off her pump. And you can see, instead of going downstairs to get something to eat, she turns off her pump to 0. She's now getting no insulin. She goes back to sleep. And what happens? The alarm goes off when she goes above 200. And what does she do? She turns her pump back on. She doesn't bolus any insulin. She just turns her pump back on, and she goes back to sleep. After the alarm goes off, there she turns her pump on. The alarm goes off again, and now she wakes up. But I see everything. It's not looking at the blood sugars. I'm looking at how these people are thinking. It's actually kind of scary. But with this download, we can do that, and we can see exactly how they're thinking. So where we are right now, when current day real-time CGM is worn 24/7 in a supportive environment with adequate education support, it can be a tremendously powerful tool. We have our first positive RCT, and insurance reimbursement in Washington State is finally improving. We are for the first time seeing insurance here in Washington covering this technology. The technology continues to improve, and the Jdrf continues to fund sensor research, because where this is all going to, obviously, in the future is hopefully for an artificial pancreas, a closed-loop device. But despite these advances, real-time CGM is very labor-intensive, and few healthcare professionals can afford this therapy in their offices because of reimbursement to them. Right now, we're just addressing reimbursement for the technology, not for the providers, so we see very little enthusiasm with the physicians. So please appreciate that CGM is still in its infancy. We've learned a lot the past few years, but we need to be patient as we learn how to best use what we have, and the technology continues to mature and to improve. What I'd really like to see is something like this iPhone, where we get a little button here for insulin, and then we also get the sensor on the iPhone with an arrow showing the blood sugars going down. This is where I think we could take it. Thank you very much.